Hello, my name is Carolina Pavlovsky. I'm from Buenos Aires, Argentina. I work in Fundaleu. And today I am going to talk about the optimal test frequency for MRD. So we know that the objectives for success in CML in 2021 are various and different. But when we are at first time with the patient and we have to select the treatment, we must have like two important decisions. And one is to choose the TKI thinking in the optimal evolution of the patient, a prolonged survival, and not progressing to accelerated phase or blast crisis. And on the other hand, we have the patient that we know that we would like to achieve a deep molecular response with the possibility to discontinue the TKI. So in these two scenarios, we have some challenges in our region because there are some important topics or important things that perhaps make a patient sometimes resistant. So as you can see, for example, in our region, we can have limited monitoring, molecular monitoring in standardized labs. Sometimes we have some problems and access with the TKI, access barriers in the TKI, some TKI copies versus branded Glivec or any TKI. So we know that in our regions, there are some important and perhaps good quality copies, but there are some that are not good quality. And also no access in 50% or more of the patient to mutational studies to adapt before the change of the TKI. So these are important things that we must consider. So we have to think that we need a long journey to achieve the deep molecular response, and this must start from the beginning. And the beginning is the diagnosis. We must consider that we must make a PCR and a cytogenetic analysis at diagnosis, and that it's important to make and monitor with quantitative PCR at optimal time points. This will give, it's an important tool to know if the patient will be adherent because we can see perhaps the fluctuations in the PCR. And it's also the molecular monitoring in for example, at month 3, it is an important prognostic factor for what is going to come. Also, we must know that a patient must not interrupt the TKI. So the patient must have a good quality of life, because if he has or she has not a good quality of life, will interrupt the TKI. And we as doctors, we must manage the adverse events. So if we manage the adverse event, the patient will have a good quality of life, and he will not interrupt. So 1 + 2 + 3 + 4 will end on treatment success, deep molecular response, and perhaps TFR. That is perhaps the objective nowadays. But we must start from the beginning, and in the Argentine Society of Hematology, the CML guidelines are very perhaps close to ELN, but with little changes. During follow-up, we recommend that the blood counts must be done every 2 weeks until complete hematologic response, then monthly every 3 months, and then every 3 months later. It's important to make the quantitative PCR every 3 months until MMR, and then if you have access, every 3 months, if not every 6 months. The cytogenetic, it's important when optimal responses are not reached. Or for example, in cases where we have patients with cytopenias, that they appear, that new cytopenias, or previous to the change to the next TKI because of failure, for example. If complete cytogenetic is achieved, some perhaps recommend to make it annually, but I think this is going to change in our guidelines also, because if we have a good PCR, we can skip this and make it 1 or 2 years annually. and then just don't make any more a cytogenetic analysis. In case of failure, yes, we must make a cytogenetic analysis, a qPCR, a mutation study, and flow cytometry to evaluate the blast crisis, the type, or the accelerated phase. It's very important to consider when we talk about PCR the development and the harmonization of the molecular monitoring methods, because we know that the PCR provides an accurate measurement of the total leukemia mass and the degree in which the P210, the P210, BCR-ABL transcripts are reduced by therapy. And this, it's important because it correlates with PFS. So it's a very important and precise method to monitor CML patients. This important tool also will inform us about the disease burden at a diagnosis, and then how these kinetics of the response goes low, deep and deep, until it makes we cannot detect the transcript anymore. So this can make us consider important decisions when we have undetectable transcripts. But it is also recommended at diagnosis to perform a qualitative reverse transcription PCR to detect the type of transcript. And this is very important in case of the TFR, future TFR. So, international scale monitoring access in middle-income countries not always is perfect, and sometimes it's difficult. Why? Well, we know that the use of different units of measurement and laboratory protocols make it difficult to compare the results between the different labs. So that's why we must have an international scale. The international scale was established a long time ago with the purpose of increasing the producibility of the analysis and between methods, allowing the clinicians to determine the significance of a change in the transcript level. So no matter in what lab you're making and you're performing the PCR, if it's standardized. But there is a challenge in 2021 in some regions, because molecular analysis is not available in every region of the world, obviously. So for this reason, in laboratories not aligned on international scale, the possibility of variation it's an issue, and thinking about TFR or about discontinuation, it's not possible. But we have in Latin America some commercial standardization regions that have made this process more feasible, and also we must consider an intensive monitoring to follow up response. In this way, we're going to follow up also adherence. And the management, we must also consider the management of adverse events, especially in non-academic centers. This is very important to take into account these 3 points: treatment adherence, follow-up response with monitoring, and adverse events, to have a success in treatment. Oh, sorry. So the conversion to the international scale in our country was a long journey that started in Adelaide with Dr. Susan Branford, that helped a lot in this standardization effort, and luckily mostly of the labs in Argentina are standardized. So it's important to have a conversion factor and to consider specific conversion factors, since there are many differences, as I have said, in the different methods. And also we must know, when we receive as a doctor the results of our patient, we must know what control gene has been used. For example, there are 3 control genes: ABL, BCR, or GAS. So it's important to know this, because we must know how many copies of the control gene have been analyzed in that sample. So international scale monitoring access in middle-income countries, it's not, as I have said, sometimes it's difficult. So considering the importance of PCR monitoring this disease, the community practice physician should in turn to perform this technique, maximizing efforts as considering referring the patient. For example, this is one important thing, to specialized centers, or if not, using available international programs throughout the world organized to support molecular monitoring. So we must consider these two things, and it's not a shame to send our patient to monitor in a reference center that is perhaps standardized. This is very important. In case this is not possible, in centers with no access to qPCR, the last option is to monitor it annually by a cytogenetic analysis or every 6 months by FISH in peripheral blood. Despite this, it is worth the effort to continue standardized labs as a central objective. So the countries that don't have a standardized lab must make an effort or must try to have some support to make it. So in CML we have some different milestones. Now, yes, we have the ELN publication, and this is very, very important because this is for all the people or all the CML patients, and it's like very unified and a guideline that everyone follows, every country. And it's important to mention that the first milestone is at month 3, and we must have a PCR. We are always talking about the same, the PCR, the importance of the PCR. So we must achieve less than 10% of BCR-ABL transcripts at month 3 by a quantitative PCR. At month 6, we must have less than 1%, and at month 12, less than 0.1%. That's achieving an MMR, major molecular response. And at any time, less than 0.1%. On the other hand, and on the other corner, we have the failure milestones. And this is very important to take into account. It's as important as the optimal milestones. Because in the optimal milestone, we know that our patient is doing well. And in the failure milestone, we have to have the red alert that the patient has to perhaps change the TKI. Just mention the month 3, that it's the month that perhaps it's more not tricky but difficult to interpret it sometimes. We must know that more than 10% it's considered a failure if it is confirmed at later 1 month or between 1 and 3 months. But we have to have this in mind. So we have during therapy the same patient with different milestones. First, obviously, the clinical survival and overall survival, and to achieve PFS. And on the other corner, the molecular achievement of deep molecular response. So molecular results are an important tool at present time as guidelines for clinical decisions, being an important prognostic factor when measured at early time points. And as I have said, the early time points are, as we can see, these suggested by the ELN at 3 months, less than 10% of BCR-ABL. This is again, and then I'm going to go to the practice part. It's important in perhaps in countries or in the real world outside clinical trials. These are some important questions to consider. For example, monitoring molecular response to TKI regularly in the same international standardized lab. When must we do that? We must do it, as I've said, every 3 months until MMR has been achieved. Then every 6 months, once MMR has been achieved and confirmed. And confirmed means 2 MMR tests. In case of borderline values, we must test again. And we have some aspects related to the warning situations. If we have monitoring transcript levels, for example, in a warning patient that it's a difficult situation, we must repeat it and monitor more frequently. Also, we must, in warning patients, evaluate treatment adherence in every visit. And ideally, to achieve a good response, the patient must have more than 90%. Also, as I have said, these warning patients, perhaps it's not It's not a warning patient, but because he's going to have a resistance in the future, but because perhaps the patient doesn't take the TKI because some adverse events. So we must manage the adverse event, treat them, and not interrupt the treatment. Also, drug interactions are very important, and consider mutation analysis in some cases in these patients. And in failure situations, repeat the test, confirm cytogenetic, mutational, treatment adherence, and obviously, and finally, changing the TKI. Another important thing is the molecular monitoring response must be done always in the same lab. As I have mentioned, the standardization is important and international scale, laboratories, and when we see that the BCR ABL rises a little bit and the kinetics of the response changes and it goes up, and a loss of MMR is confirmed, the test should be repeated in a short interval. And patients should be questioned carefully about compliance, drug interaction, and assess a cytogenetic and mutational analysis. But we must know also that sequential small fluctuations in BCR-ABL transcript levels in deep molecular response 4.0, 4.5, or 5.0 is sometimes unavoidable because it's part of the laboratory technical reasons. So we must be careful about this and not think that the patient is relapsing because if the patient has a MR undetectable, or 5.0, and then in the next test he has a 4.0. That's the same, it's a fluctuation, and we must consider perhaps continuing the test every 3 months or 6. Consider survival predictors. MMR is one of the best predictors of survival, and we know that discontinuation therapy is a controversial aspect that can only be considered under clinical trials or special situations in low-income countries. This is not the subject of today, but it's very important to take this into account. A standardized lab that ensures high sensitivity monitoring is needed to assess deep molecular responses and a strict monitoring. So TFR is not for everyone. We can make it in the real world, but in low-income countries, this is a matter of debate today. Practical aspects for molecular monitoring in the real world are some lab aspects also. Selecting a reliable standard lab and peripheral samples also. It's important to take into account that must be from peripheral blood, it's not need to be from bone marrow. It's better to take 20 milliliters, no less than 10. And also peripheral blood should be used, as I have said, instead of bone marrow. They're comparable results. If you deliver the sample to a central lab, for example, in my country, in Argentina, it's a very long country, perhaps we cannot have the samples immediately, and some patients can bring them in 24 hours. That's not the ideal situation because we must done no later than 24 hours. And results analyzed in a standardized lab that expresses BCR-ABL transcript must consider the ratio, as I mentioned, between the copy number of BCR-ABL and the control gene. Repeat again that if you don't have an access to molecular monitoring, just use what you have, cytogenetics or FISH. TFR in emerging regions. Is molecular monitoring a big issue? The answer is yes, because perhaps we want to discontinue treatment in Latin America or in low-income countries. But what's the big issue? The big issue is that the patient, after interrupting, perhaps doesn't have molecular monitoring make as it's recommended, and this is perhaps a little bit risky. So discontinuation must be done under strict conditions that involve both physician and the patient. The patient must know this. We must assure not only a close patient follow-up, but also access to international scale labs, a proper frequency of molecular monitoring after TKI interruption, and also generate a safe environment in this population, because it's not the same to discontinue in a clinical trial that to discontinue in the real world. And if this real world is a low-income country, this could be very risky. So I don't say that we can't do it. We are making this under a program in Argentina, but very with close follow-up of the patients. So since this was currently not a viable reality for most centers in Argentina, a multicentric study, as I have said, on discontinuation in the real world has initiated. And there's an economic issue also in low-income countries or in middle-income countries, because there are some economic problems that we must consider. And one of these is the poor distribution of the population. There are very different types of population, more richest, more poor, and with no access to monitoring, with no access to drugs. So this is an issue that must be considered, but because it matters to all the doctors. It's very important to solve these problems about the lack of resources, about this poor distribution and poor lack of availability to have TKI and access to drugs. Private versus public patients, it's also different, because the private ones can have access to all, and the public and who are treated in hospitals perhaps don't have access to monitoring. So this is an issue. And no data about efficacy of TKI copies, perhaps about generics and about copies there has been published a few data, but we need continue research in generics and copies. So my final message is that today CML has very effective treatments because we have a lot of TKIs, and we can have access in some less, some more, but this is not all. This must be accompanied by a close monitoring with access to sensitive methods, especially during the first stage of the disease. In this way, we will have high chances of success, not only to control disease response, but to be aware of patients' treatment adherence. These are the first steps, as I have said, of the long journey that can end in drug discontinuation. Sharing with our patients the goal of therapy helps to identify the needs and obviously improve patients' care. That is our objective as doctors. Thank you, and with this I end and thank the CML Foundation for this consideration and invitation.